Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Professor Eric Lim, and it's a great delight for me to present Professor Martin Forster from UCL this week, who's talking to us about cellular therapies in non-small cell lung cancer, which I think is going to be a very important adjunct, especially looking for the future. As always, our sessions are brought to you at no cost, thanks to our sponsors, Medtronic and AstraZeneca, and also our affiliate partners, Medela, the Science of Care. Over to you, Martin.
Thank you very much, Eric. Thank you, everyone, for listening today. It's an absolute pleasure to be having this discussion with you around what I think, as Eric has said, is hopefully an exciting future treatment we have for lung cancer. As you heard, my name is Martin Forster. I'm a medical oncologist based at UCL in London. These are my disclosures. So when I was in training, this was the sort of Kaplan-Meier curves that we were seeing from the trials, global trials, really. Often this study had more than 1,000 participants, and you can see really no daylight between those survival curves, as well as very dismal overall survival for patients with metastatic disease. I think those of you involved in the management of patients with lung cancers will agree that even in the treatment of advanced disease, it's a very exciting time at the moment, in part because of the better understanding that we have of underlying cancer biology, which has led to the recognition of some of the drivers that happen as part of that carcinogenic process and the development of drugs to inhibit those. And many of these drugs you'll be aware of targeting EGFR, ALK, different therapies. Of course, there's still a lot of patients we have on a day-to-day basis who don't have these drivers. And it's, just incredible that for that patient population, we also have novel therapeutics, and we are really on the forefront of the cutting edge of immunotherapeutics with checkpoint inhibitors as well. Seeing what's so exciting is the change in the curve of these survival curves we see with immunotherapies, with some people doing really well for a long time. Of course, what we still lack is very good predictive biomarkers to be able to select who's going to get that benefit. And so what we're going to focus on today, in a way, is how we can try and combine those two advances: better understanding about the cancer biology, better understanding about immune regulation, better technology to develop novel therapeutics, and putting that together really to try and develop precision immunotherapy. And there's quite a lot of different types of advanced therapeutics that we're exploring in clinical trials in lung cancer at the moment. And we're going to focus today on cell therapies, but you'll no doubt be aware from colleagues, from your own experiences, or indeed from the media, about other approaches which are trying to use this approach of precision immunotherapy, such as those vaccines, whether they're personalized or non-personalized vaccine, which is very exciting in lung cancer at the moment in clinical trials, or indeed antibody technologies and allowing us to target multiple different targets at once, bispecific, even trispecific antibodies, including some of those immune engaging antibodies, which are so exciting coming through. But today we're going to focus on cell therapies, and there are different types of cell therapies, and I'm just going to give a very high level discussion about some of those, some of the potentials and some of the challenges around that, particularly around CAR T cell therapies, TCR therapies, and tumor infiltrating lymphocyte therapies. We've been doing trials in mesenchymal stem cells as well. There's other sorts of cells you can use, but the top three in red there are the ones that most people are most active in at the moment. So a CAR T, essentially, this is this chimeric antigen receptor T cell therapy. This is also a sort of antibody technology in a way. For these products to be developed, you need to take a whole load of cells from a patient. So this is an autologous product taken usually through apheresis, and then out of the body, you're manipulating those cells to express an extracellular domain, predominantly this CAR, a new receptor, which can be designed to bind any sort of antigen that you want. And the first generation of these sorts of CARs were particularly active in hematological malignancies, particularly CD19 has been their primary target. And even in those malignancies, it was recognized that these products could be improved upon through incredible engineering to change different other components of the antibody of the receptor to change its activity, and some of those may be on the in the hinge area, or a lot of them in the intracellular component, which also have activities. I'm going to talk a little bit about some of those in a minute. So, as I say, this really started in hematological malignancies, and there's a number of CD19 approved products, one of which was developed at UCL. We have a big research interest in CARs at UCL. So in hematological malignancies, these are now a standard treatment option for some patients, particularly with the B-cell malignancies. In solid cancers, there's a number of challenges around this, but it's still being explored with great excitement. And there's hundreds of trials, literally hundreds of trials looking in different solid cancers. And, you know, when I last looked, more than 25 studies in lung cancer itself. Most of these are either in non-small cell lung cancer, but there's also some really interesting work in mesothelioma. And you can imagine, if you look here at what you're going to have as your target, this is actually very important. And if you just look at lung cancer, some of these things you would recognize through the discussions that we have in our MDTs, and some of those targeted therapies that we've been developing, things like EGFR, HER2, CEA. Some of the other ones will be less well known, and these are sort of targets which have been developed or being looked at least in the clinic at the moment. If we just step back conceptually and think, well, actually, what makes a good target? Because this is one of the real challenges in solid malignancy CAR or cell therapies in general, really. You need to have something, first of all, ideally, that's expressed in all of your cancer cells. So you want something that's what we would call a clonal target, so something that's in every cell. And you want it to be unique to the tumor, ideally, so that it's not expressed on lots of healthy cells. So, and then you need to have something that's actually going to be recognized by the immune system as being foreign. So there's different complexity around selecting that target, which has actually been one of the really big challenges about trying to use this technology, which exists in hematological malignancies, into lung cancer. And there's other challenges as well. So one of them is this real challenge about finding the right target. But other factors around the fact that, unlike a blood cancer, which is obviously in the cells are in the blood, our lung cancers are solid tumors, and that adds other complexities. The penetration that the products have to get into the tumor, and as we have well understood, the fact that that tumor microenvironment is often very immunosuppressive, making it which adds a challenge to try and have these, give the cells a chance to kick off an immune response. The other factor, which I think is a bit more practical, is that these are quite complicated therapies. In order to develop a CAR, you have to first of all have apheresis, remove the cells. That's something which is relatively straightforward these days in the hematological department. Then manipulate them with this very precision technology ex vivo, so out of the body. But then to deliver them back in again for all of these cell products, you have to create space within the sort of white cell population, and in doing so, you use lymphodepletion. So you deplete the body's immune cells using quite intensive chemotherapy, and then you can give the product in to try and to get into that space to give it chance to engraft and enlarge and therefore have a prolonged effect. And because you're giving these manipulated cells the risk of cell-specific side effects, which you need to manage, things like cytokine release and neurological toxicities. So these are not straightforward products to give in any population, and obviously in a lung cancer population where we often have multiple comorbidities, that's particularly challenging. So some of these challenges are being looked at now in at least in concept and in preclinical models, and increasingly now coming out into the clinic. Obviously, this is all in the world of clinical trials. They haven't really quite got to the space of being approved, but looking at how you can overcome some of those challenges by those second, third, fourth, now even fifth generation products, which have got these other factors. So not just the antigen binding component on the outside, but other things on the inside, which can change once those lymphocytes are in the body, can change the microenvironment and such like. So, for example, approaches to increase or overcome some of that antigen heterogeneity. You can have more than one product, or you can have something that targets a more common product, which leading to release of multiple different factors. So you maybe then have a broader effect within the tumor rather than it being restricted to a single target. You can look at different ways of trying to reduce the toxicity off target, either by, again, having multiple targets. If you have multiple antigens which have to bind together, then it's more likely to happen in the tumor environment than it is on other cells elsewhere. Or indeed having these suicide gene systems. These are quite common now, where in the wrong microenvironment, the lymphocytes are killed through these suicide gene systems, which are built into the product. So incredibly clever technology. Similarly, you can manipulate the product to secrete different things, such as chemokines, to try and attract and keep the immune cells in the tumor microenvironment, but also mechanically. And this has been done quite a lot in mesothelioma, where the CARs are injected into the pleural space, so that you're giving them the proximity, physical proximity into the area where the tumor is, to try and reduce the distribution around the body and focus it more, and particularly on those mesothelin CARs, which have been explored quite a lot in the US, and they're on third generation products now, to try and see if they can see activity there. Other ways of trying to manipulate the CAR to overcome the microenvironment can happen through secreting other things, as well as those sort of attractive chemokines. You can secrete DPD1 to try and engage the immune system a little bit more and change the microenvironment. So lots of manipulation which can be done. This is obviously becomes incredibly complex technology to manipulate these CARs that you're going to then introduce onto the individual patients' lymphocytes outside of the body before you reintroduce them back into the body. But this is the sort of technology that's being explored at the moment in clinical trials in lung cancer. One of the limitations of a CAR is that it can only target an antigen which is on the surface of the cell, because that extracellular bit can only bind extracellular antigens, or tumor surface antigens at least. So one of the other approaches when it comes to cell therapy is looking at TCR engineered T cells. So in these circumstances, the product development in some ways is not dissimilar, in the sense that you're taking the patient's own white cells. Again, you're doing lymphodepletion. You're doing apheresis and removing the cells ex vivo. You're then manipulating and enduring those cells, but with a TCR rather than with this CAR product. And the advantage of that is that you can potentially then targets which are normally within the cancer cell. So you're expanding your possible targets to intracellular targets, so long as they're being expressed on the surface through a MHC complex, which you'll know is basically designed to express different peptides to the immune system via this TCR program. So this means that there's a positive, that you can expand your potential targets to intracellular targets as well. But there's a negative, because they need to be, you're restricted to be able to do that in HLA subtypes. So you have to be able to screen your population to know they've got a certain subtype of HCA, that they're going to be expressing that peptide properly. So these TCRs actually are also particularly lots of activity over the last few years in lung cancer and other solid cancers. One of them, to NY-ESO, has recently been approved in sarcoma. So these have got some proof of concept. But in lung cancer, they're still under active discussion. The process for this then is also quite complicated. You're having to select your patients, HLA screen them, then antigen screen them to see if their tumors expressing the antigen that you're targeting. You can see some of the examples that are being used in lung cancer at the moment, particularly the sort of testicular tumors, like antigens like NY-ESO or MAGE, the different MAGE A1, A4. There's a number of TCR products in the UK in trials at the moment looking at this approach. the screening protocols is something which is going to make this a little bit more feasible, because certainly the studies we've been involved in, you do huge amounts of screening to get your matched patients who've got the right HLA and the antigen that you've got your trial for. You then have to arrange when they're at the time of progression or an appropriate time to do the apheresis to build a product and then give it back to them. And in lung cancer, often that's just not very feasible. Those windows when patients are well are unfortunately not that common and not that long. So the idea that you maybe can do some of this screening in advance, and you may have a number of different products available for different antigens, which will be ready for you, is certainly one of the approaches which is going forward, and also moving away from some of these initial targets into some of those mutated neoantigen targets that we know so well in our lung cancer patients. Obviously, they're rarer populations potentially, but perhaps more tumor specific. They do have this similar challenges as well as that TCR match. You still have to select the right target. You've still got the risk of on-target, off-tumor toxicity if the target's not unique to the cancer, as is the case for most of the products at the moment. And you've still got those same problems about the suppressive tumor microenvironment. So it's still got the similar challenges about how to deliver this in a patient population like lung cancer, and again the same delivery issues, because they do need the lymphodepletion and in order to deliver the cells and give them a chance of embedding and grafting and giving longevity of their benefit and the associated toxicity of that. Finally, I'm going to just briefly touch upon the idea of TIL therapies. So this is another approach which is quite exciting, particularly in solid cancers, and last year was approved in melanoma. Here's a slightly different concept in the sense of product development. So here it's also an autologous product, so it's patient specific, but here you have a surgical biopsy where you're actually removing part of the tumor, at least with the modern technologies. You're removing part of the tumor. From that, you're extracting the lymphocytes. So these are tumor infiltrating lymphocytes, but inherently, therefore, these are not lymphocytes to one specific target like you've got with either TCR or with CAR T cell products. Here you're going to have a mixed target potential, because you've got lots of different immune cells within that, and they're taken out of the body, expanded out of the body, and then delivered back to the patient. And in melanoma, which was this tumor type which is most advanced, there was some really quite promising activity seen, and you can see here in the waterfall plots quite good response rates, and again those Kaplan-Meier curves, even in patients such as in this study who've already progressed after checkpoint inhibition, you can see that tail on the curve where some patients are getting long and meaningful benefit. The early phase studies by Iovance, who developed that product, which is now licensed and approved in melanoma, and hopefully going to be available here in the UK sometime later this year. It's going through review with NICE and such like for reimbursement at the moment. Also there's a number of cohorts looking in lung cancer, and that's also looking quite exciting, with significant responses in around about 20% of patients. And this trial is ongoing. It's happening in a number of sites here in London, as well as across the UK and globally. So the idea of translating the benefits we've seen in melanoma into lung cancer is an active and ongoing process. We actually at UCL, through the spin out Achilles, look to try and do one step further than the TIL, the off-the-shelf TILs, if you like, or the Iovance TILs, where you're using just an expanded product, by trying to actually expand and enrich that product for clonal for lymphocytes which were reactive against clonal neoantigens. Unfortunately, this program has had to close now because although the technology allowed us to do this, the practicality of delivering this in a patient population at the moment, in the way the clinical services are, was just really not really possible. So there's ways of advancing these TIL products as well, which is under evaluation. So in conclusion, I think it's too early for these products to be in the day-to-day. So most people will not have come across these in their as tools to use for their patients, but very exciting advances, both in the context of new next generation CAR products, which will have improved activity and safety in lung cancers, particularly in mesothelioma at the moment. Looking at different TCR products, and also excited to see how these TIL products behave in lung cancer. And on that note, I'd like to finish and invite some questions.
Excellent, Martin. Thank you very much for another excellent presentation, as always. This is, I think, a really exciting field. When do you think that the first onset of cellular therapies will actually reach clinical practice, given that a number of clinical trials are underway at the moment?
Yeah, well, so I think in if we think about solid cancers in general, the TIL product was approved last year by FDA. It's being looked at by the MHRA here in the UK. So I think that will become a product available in melanoma at least, hopefully in the UK over this by the end of this year.
Wow, it's incredible.
It's amazing. And that will, in some ways, a bit like when the checkpoints first came through in the melanoma, that kind of prepares the space because these are obviously complex therapies to deliver. But within specialist institutions where they have the capacity to do that, I think that will be coming through, and that will prepare the space for more common cancers like lung cancer. And as I say, the TIL study is being designed in a way that if the activity is adequate, it will hopefully be a registration study, even though it's a single arm trial. So potentially in the next year or two, there could well be a space for those TILs. I think the engineered T cell, whether they're TCRs or CARs, they're going to be a bit more challenging. I think they're very exciting, but I think that they're a bit further off mainstay clinical use because the trials are still evaluating and refining the products.
That's incredible because it always seems so futuristic, but to actually have, a deadline within a few, 12 to 24 months seems to me like just on the cusp of coming into what we're going to be regarding as routine practice going forward. Can I ask, there's a great question from Dr. Anand Patel, who's interested to know about, how long does it take to manufacture, say, TILs, and, how much money would it cost, per patient to make up such a regimen?
Yeah, so so the time is for a standard till product it does take a few weeks. So it takes 3 or 4 weeks to be made. So that's part of the process, the challenge around sort of selecting the right patients where this would be relevant, where you think you've got the time to do that apheresis, whether it's for a CAR or the actual surgical biopsy for a TIL. So there's a bit of patient selection, there's education we need to learn about that. In context of cost, like all these things, they seem mind-bogglingly expensive, and in the hematological practices, the CARs and which have been approved, the prices are coming crashing right down now. At least the NHS is forcing us to pay less for them. So I think that they are currently, hundreds of thousands of pounds. But I think that the price will come down.
Wow, incredible. Um, and can I ask, how much cells do you typically need? Because I'm super interested in this topic, and I'm sure many surgeons are, because, in the advanced cancer setting, traditionally, it's not a place for surgeons. And with cell therapies going forward, advances in oligometastatic radical treatment, there may be a future where stage 4 disease, will still come to the surgeon, either as, a radical resection for limited disease, or in conjunction to harvest cell therapy. So can I ask how much cells do you need, say, for TIL therapy?
Yeah, so it's a good question, and you can imagine it's something we're still learning about. Certainly, our experience with the trials that we've been involved in, the quality of the surgical sample is very important as well. So for example, whether the tissue which is growing has been irradiated in the past, or so there's various different factors that may be different factors, though it hasn't been experienced yet, at least in melanoma, about whether it's a nodal resection or a primary tumor resection or a metastatectomy. So there's a number of factors we don't know very well. But in practical terms, you're looking at sort of around about a centimeter cubed volume of tumor is what you're aiming to do in order to get what will be millions of cells of TILs. But that's the sort of amount of tissue that you're aiming to try and get for at least a centimeter cubed. So a reasonable sort of size, but certainly not crazy large when you think about the tumors that our patients with advanced disease have.
Oh, excellent. Because such a small volume, conceivably they could even be done as a day case surgery. So I think that's going to be where thoracic surgery is going to move towards in the near future. We've got some questions from Dr. Abdul Sam, who's asking, traditionally CARs are coupled onto surface antigens, so on and so forth. Is it possible or consideration for it to be coupled with other more simple molecules like glucose, such that patients with high PET uptake can have a better penetrations into the cancer cells?
Oh wow, gosh. Um, so um, I guess what you're wanting to do is try to have your binding to something that's quite tumor specific. So I guess I mean, you can do it to anything, but I guess one of the challenges is if you're binding to something that's actually expressed in quite a lot of normal tissue as well, then that becomes a problem whether you're getting your on target off tumor side effects. So I think that the potentially, if it was going to be some co-expression and you were going to have a tumor specific thing and then a second binding, which you can do now, which is linked to something which is more commonly expressed, that would be a possibility. Although most of the focus is around potentially two tumor targets, for example, which then might give you more specificity to the tumor environment. Because one of the real challenges is getting something that isn't causing too much normal tissue toxicity.
Thank you. There's a question from Dr. Therese who's asking, given the explosion of immunotherapies, do you think an immunologist or clinical immunologist will become the standard for the MDT in the future?
Yeah, well, it's interesting. I mean, at the moment, immunologists are certainly massively important within our laboratory, as are the bioinformaticians. So the science is very much driven by immunologists. I think when it comes to the clinical practice, I guess it depends a little bit on how good our or how complex our biomarkers are. I mean, in a way, if you think about the molecular pathology that we're looking at with our NGS sequencing of our tumors, you could argue that you need a clinical geneticist in our MDTs, but actually that's translated into a language that is practical without that on a day-to-day basis. But we reach out to them for complex cases. So I think probably the day-to-day MDT won't require an immunologist within it, at least for the moment, but understanding some of the tests that we do and putting them into context of the patients and how we're going to use those results is definitely getting more complicated. And I guess that's something where we may get tumor boards or which are going to add that expertise from different aspects, which we don't have in our day-to-day clinical MDTs.
Question from Dr. Ahmed is asking, traditionally treatments in advanced disease slowly percolate down to early stage resectable setting. Do you see any future in these cell-based therapies for completely resected tumors targeting the micrometastatic disease? Or at the moment, is it something only for like visual large volume disease?
Wow, that's a really interesting question. And I think I mean, obviously, it's a challenging environment, and we're seeing that transition if you step back from cell therapies to these complex advanced therapies and think about vaccines. We're seeing that already, aren't we? They're kind of almost bypassing the advanced disease and going straight to the perioperative setting because I think immunologically, it makes a lot of sense to be using these immune type complex immune therapies in a time of small burden of disease. So actually, there's quite a lot of arguments of not only of having small burden disease, but also having a very sort of a competent immune system, which is only going to be compromised after multiple lines of chemo and other systemic therapies. So there's definitely arguments for doing that. And we're seeing that in relatively non-toxic treatments like vaccines in that perioperative space. I guess one of the challenges about the cell therapies at the moment is they're quite complex to deliver. Hospitalization, significant risk of quite, real toxicity. I don't think we're ready to be delivering that, at least until we've got much higher levels of activity than we've seen so far into that potentially curative space. But in the long term, hopefully that will be a possibility.
Yeah, and on that note, Dr. Patel is asking how, given the amount of, how difficult it is to administer and toxicities, how fit do our patients need to be able to receive cell therapies today?
Yeah, so I mean, they do definitely have to be fit. I mean, they have to be fit physiologically in the sense of their cardiorespiratory sort of reserves, as well as their kind of more kind of blunt tools that we're used to using in cancer trials of performance status and that sort of global thing. Um, they don't need to be superhuman. But I think one of the challenges of about using these sort of products in solid cancer patients is the fact that they're not the young, healthy sort of 20-year-olds who get leukemia and other, unfortunately, our older patients with smoking-related comorbidities, etc., are definitely do have challenges. So I think it's not going to be a treatment that's going to suit everybody. I think it's definitely going to always be somewhat selected for the patient population who are particularly fit. But obviously, if we can see significant cures, then it's still got a role to play in that population. But it's not going to be a sort of treatment for everybody, I don't think.
Excellent. Thank you so much, Martin. As always, there's so many more questions than we have time for answers today, which leads me once again to thank our sponsors, AstraZeneca and Medtronic and Medillia, the Science of Care. Next week, we don't have a meeting because it's the American Association of Thoracic Surgeons annual meeting, and we'll come back the week after that with Dr. David Blanchard, who's going to talk to us about new treatments for lung cancer. So once again, Martin, thank you so much for your excellent talk today. And
Absolute pleasure. Thank
thank
you.
you. Bye-bye.
Bye.